Subscribe to our YouTube channel and don't forget to press the bell icon to get all the latest updates. Here at the SRV Covid Hospital in Mumbai, we are going to talk to one of the state's foremost Covid warriors, Dr Swaroop Hegde, who has been recognized for how many thousands of people he has helped recover from Covid. As India battles its second wave, what are the main challenges on the ground and what should we be taking note of and keeping in mind? Hi, Doc. Thanks for making the time. Let me start by asking you to tell us, I've been doing a round of hospitals and I know that certain critical things are in short supply: oxygen, beds, and medicines. Let's talk first about medicines. Remdesivir, there's more than one opinion on whether it works or not. Let me first ask you, are you somebody who uses Remdesivir?
We do use Remdesivir. It does certainly work, but it needs to be given before the 8th day period. So if you give Remdesivir probably beyond the 8, 9, 10 day period, or after you have had a cytokine storm, the effects are significantly lower, and the results of Remdesivir are slightly lower in patients who are admitted in the ICU, probably a category C pneumonia. So ideally, in most cases, you want to admit the patient a little early and hit them early with Remdesivir, because the later you give the drug, it probably works less, because by that time the viral load is such significantly high that it's not exactly a game changer.
So how are the supplies of Remdesivir doing at this point?
As of right now, we have an absolute shortage of Remdesivir. That's simply because we have a significant number of patients who actually need the drug. At the same time, the pharma companies haven't been able to keep up with the stocks. For the last couple of weeks, we've probably been getting it out of the black market, but I think the government has just brought in a legislation which disallows getting Remdesivir from outside.
But you're severely short?
We are significantly short. Considering we're a 100-bed hospital, we are using about 100 vials a day. That would translate into at least 3,000 plus vials a month. So we don't really we have a gross mismatch, because even the companies cannot provide us more than 500 vials.
So hang on. So you use roughly how many a day and how many do you have?
Well,
how many do you need to use and how many do you have?
On a given day, let's say if out of 100 admissions, there would be at least about 75 to 80% of the patients would be on Remdesivir. As of the last 1 week, yeah, we have been having to either change most of them to convert them to oral therapy. And for the others, well, we as of now have been asking the relatives to get it from out. So some people have been getting it from the black market, some people from other cities possibly. But there is a significant shortage.
And the other big drug, of course, is Toxizumab. How are you doing on the supplies of that?
Now, Tocilizumab is used highly specifically only for cytokine storms in the initial period. It does work to a certain extent, but again, that drug has been in absolute shortage simply because we do not have more than one company producing it. Cipla is the only one who manufactures it.
And it normally produces it, if we can walk this way, normally produces it for arthritis, right?
Yes, it's an actual drug used for rheumatoid arthritis, which was in Buffalo University last year. It was identified as for the interleukin count to basically bring it down is where it was being used. So it was on a trial error basis it was being used. It's not exactly a game changer, but it certainly helps in bringing down the severity of the disease. So in some cases it works, some cases it doesn't. But yes, it's an integral part of COVID treatment.
And how short are you?
We actually have, at least unlike Remdesivir, where we still have some access of it to the black market, in the case of Tocilizumab, we have no access. There is an alternative drug called Itolizumab, but the ICMR right now and WHO have disapproved its use as of now for COVID.
So how are you managing without the Toxi?
Well, as of right now, what we do is we give them a higher dose of steroids. But like I said, Tocilizumab is not necessarily a mandatory drug to be used in COVID. So you can get away without it. But the same doesn't apply for Remdesivir, because that is the primary treatment drug as far as COVID hospitals are concerned.
So it's a pretty dire situation. I've been, outside of Mumbai. I went to Vasai. I saw 8 people die in one hospital because there wasn't enough oxygen. Oxygen is obviously really in short supply.
Now we are kind of reaching the scary scenario, because we could do without a Remdesivir and we could do without a Tocilizumab. But what's really happening is that the state has overshot the output that we use basically for oxygen. So most hospitals, including us now, we are on the tenterhooks, because we ourselves are on the last 10% of the oxygen. So maybe we're going to have to decide what kind of patients we want to admit, probably take in patients who require less oxygen, maybe undercut the oxygen we're going to give to the patients, stop using high flow cannulas, but that will automatically compromise the entire line of treatment. So it might actually translate to higher mortality now.
You're saying that because we don't have enough oxygen, you've got to change how you're treating patients, and how you're treating patients could cost more lives.
Absolutely true.
So it's a really, really dire situation. How is this strain or this wave different from what you saw in 2020?
In 2020, the strain was much milder. The original strain was much milder. it did respond to basic drugs, some of the over-the-counter azithromycin and ivermectin that was available. The current one is definitely more, has a more virulent strain. It's definitely more infectious. It definitely causes a high amount of pneumonia. And if not treated very aggressively, it can definitely translate into a higher mortality rate.
I was just going to ask you that because, you know, in 2020, Indians were celebrating is the wrong word, but drawing some relief from the fact that our mortality as a percentage of population, our IFR, was down compared to the rest of the world. So we clearly had massive cases. Serological surveys seem to point to the fact that many of us may have been asymptomatically positive, but not as many of us were dying. We know that this strain is more infective. Is it more lethal or do we not know yet?
Well, I do believe that definitely the strain is definitely more lethal. It is right now, it hasn't translated into a significant mortality simply because we had the adequate drugs as far as Remdesivir and drugs like that were concerned, which were not there last year. But now that we have reached a threshold as far as oxygen and Remdesivir is present, it means that a lot of people are going to be denied hospital bed, they're going to be denied oxygen, and those who are critical are not going to get the kind of treatment that they want. So one would expect that if things do not go downward, which means the number of cases do not exponentially go down, we will actually see a significant rise in mortality over the next 15 days.
So what can we do, Doc?
The only option right now that the government could have is one is you need to enforce the pharma companies to actually increase the basic production. They did have a substantial period of time to do that. That was one aspect. Second point is that the government is going to have to contemplate treatment of COVID even at some of the non-COVID hospitals, because right now there are very few.
But they still won't have the Remdesivir and the Toxi and the oxygen.
Yeah, but at least they would have some limited oxygen supply, some basic medical treatment available, because as of right now, the only resources that people who don't get a bed have is that they have to take home oxygen and be quarantined at home till they get a bed.
Would you advise people not to rush to hospital?
I would advise those people who are clinically not very symptomatic to not come and block a bed, because when people who do not have significant issues, when I'm talking about it, I'm talking about a lot of people who do not have oxygen requirement, but out of pure apprehension, because there's so much of fear around COVID, they come and get admitted in the hospital. Now, we as doctors cannot really choose to tell someone not to get admitted, because if they get critical later, they may put it on us. But also what results is there are a lot of cases which can be managed at home, but which are actually lining up in a COVID hospital, which is blocking the bed for those who are requiring it more.
What about vaccines? Are we too late on that curve?
The problem with the vaccine is, number one, is that we have had issues with the vaccine. I mean, there have been people who have been getting either some sort of fever or a pneumonia or a COVID-like symptom due to the vaccine itself. Many people have turned out to be positive with a couple of the vaccines which are currently in the market. Not denying that people still have to take the vaccine, but that has not in its totality really helped us the way we wanted it to help.
One thing that would help right now, I just want to have something that we can, give people a context to feel better about. You are also seeing much younger people, you were telling me.
Yes, we are seeing, unlike the earlier strain, we are seeing now even kids who are about 5-8 years having pneumonia, which was
5 and 8.
5 and 8 who never had pneumonia in the earlier strain. They are also getting quite significantly symptomatic, which means that they do get breathless and they do require significant treatment. The only solution now is that people need to rigidly enforce wearing a mask. The one and single thing that actually helps you in COVID is just wearing a simple mask. It could be a home mask, it could be a 3-ply mask, it could be just about anything. Either you wear a mask or follow a 6 feet social distancing. That is enough for you to not get COVID. And the second advice would be that if you get a fever, please go see your consultant, get a C-reactive protein test done. You see a higher number than normal, that means you are possibly staring at a COVID. I mean, unless, of course, you can rule out typhoid, dengue, and the other comorbidity. But loss of appetite, fever with generalized weakness, these are predominant complaints that come on day one. And if you identify the symptom on day one, COVID can 95% be cured in OPD itself. The problem is that most people, by the time they present to the doctor, they're already on day 5. By the time he even identifies it's COVID, it's another 5 days. So by the time they come to us, they're already well past the period.
So test early and
get medical attention early. The earlier government opinion that you could just sit at home and self-isolate is now going to go against the patient. Rather, if you're having fever, please see a good consultant and get a C-reactive protein done and investigate early and start the oral therapy that is currently available, favipiravir being one of them, to start it early. It is not a game-changing medicine, but it will certainly reduce the number of admissions by at least about 30-40%.
So we really need to pay attention to Dr. Hegde there, who's saying that we're at the threshold of running short of literally everything that matters: oxygen, beds, the critical drugs. But do not crowd the hospitals. unless you really need to, which means do not ignore the fever and hope that it will go away. You could stay at home, but only if you seek medical intervention fast enough. Younger people are getting it, kids are getting it. Wear that mask. A simple mask is enough, but please do not take off your mask. It's great to see you here. Thank you for watching our work. If you haven't subscribed yet, don't forget to click the bell icon and subscribe to Mojo Story and support independent, robust journalism.